Good morning, audience. I want to thank Dr. Krishna and Nandi for including me in this course. I'll be speaking on indocyanine angiography in an era of OCT angiography and fundus fluorescent angiography. There are only very few occasions where we need ICG angiography. So I will go along like a case-based approach where angiography or OCT is not giving us enough information to treat the patient. So we'll see the cases where ICG angiography is indicated and how does it help in clinical decision making. So basically we'll go through the slides like this. What is indocyanine angiography? How does ICG work? And why not fluorescent angiography alone? Why does not it alone suffices? And where are the instances where we actually need ICG angiography? So what is indocyanine angiography? So it's a tricarbocyanine dry, soluble in both water and lipid, high molecular weight, it's got high plasma protein binding, and it fluoresces as infrared region 790 and 835. The importance of this is it can penetrate blood. So if there is a lot of blood or exudates, specifically blood over the retina, information for angiography is very less. In this case is indocyanine angiography, which can penetrate the blood and give information of the choroidal layer. So how does ICG work? It has got similar phases like the fluorescent angiogram. It has an early phase, a mid phase, late mid phase, and a late phase. So basically in cases of IPCV, which is the most useful diagnostic modality for ICG, we have to wait till 6 minutes till deciding whether there are polyps or not. So 6 minutes we must wait. So what are the advantages of ICGA? So it gives us a better definition of choroidal vasculature and is a relatively safe dye. The important difference is it is excreted by liver, not by kidney. As we know in renal diseases, angiography is contraindicated, but in renal disease you can actually do ICG angiography. The contraindications are basically same, allergy to iodine, and it is always avoidable in pregnancy. So why do ICG? So coming to a clinical situation, you can see a 60-year-old lady. These are classically AMD lesions. Yeah, so basically you can see there is a lot of hemorrhage, hard exudates, and a large area of fibrovascular PED or hemorrhagic PED-like thing. So this is the angiography. The angiography is not much informative. You can see there is some amount of hyperfluorescence coming out here, but this area is showing nothing. But the moment you do ICG, the clinical picture is dramatic. So you can see these are large feeder vessels. These are branching vascular networks, and these are feeding these small light bulb structures, which are basically, these are the polyps at the end of the branching vascular networks. So this is a classical case of IPCV, which obviously you can never pick up without doing an ICG angiography. So here you can see nicely all the things. It's a hemorrhagic PED which has become hyperfluorescent. You can see the vascular nets, the dilated choroidal vessels. You can see this is a very large vascular net which is going and supplying this nice polyps at the end of this. So ICG is absolutely essential to diagnose cases of IPCV. So basically these are the conditions where we need ICG in present day clinical practice. Occult choroidal neovascular membranes, retinal angiomatous proliferation, PCV, CSR in some cases, retinal artery macroaneurysm, some cases of intraocular tumors, and chorioretinal inflammatory diseases. So coming to another representative case, you can see a hemorrhagic PED here, a lot of hard exudations here. So this is the fluorescent angiography. You can see this is the subretinal blood, and this is the PED that is filling up. And this is the ICG. It just gives an information about the membrane here. So the question that most of the people ask is, why do you need to think of whether it is PCV or anti-VEGF or an AMD-related lesion when we are anyway going to treat with anti-VEGF? So all AMDs we treat with anti-VEGFs. What is the need of doing an ICG and wasting patients' time? And what clinical importance, how does it affect how we intervene in the patient? So intervention is very important. So we'll see few slides, few cases where ICG really changes the clinical management of the patient. So here is an 80-year-old lady. You can see small hemorrhages here and an elevated lesion here. So you do a fundus fluorescent angiography, you see a PED filling up and a late leakage in this area. So you are not able to clearly differentiate whether it is a CNVM or a PCV or something else. But the moment you do a ICG, what you can see very nicely is there is an anastomosis of these two vessels. So this is a classic RAP lesion where you see there are two vessels anastomosing and forming a lesion here. So unlike CNVM secondary to age-related macular degeneration, we have to remember RAP lesions are very much intolerant to anti-VEGF alone. So if you are going to treat RAP lesions with injections alone, they are not going to improve. So you can keep on injecting them from 10, 15, 20 injections, it is going to be the same. Either you have to combine some sort of laser therapy or PDT to treat these RAP lesions. Basically, you have to go after this anastomosis. ICG helps us to pinpoint where this anastomosis is occurring, and you can treat them either with PDT or with a focal laser, then combine with anti-VEGF. Whether fundus fluorescein angiogram, it gives us information there is something happening here, but it does not tell us what is the exact lesion. So that is where ICG is very important in picking up RAP lesions. So any elderly gentleman coming with a fibrovascular PED with small punctate hemorrhages, always keep RAP lesion in your suspicion and always order an ICG. So any elderly gentleman with small punctate intraretinal hemorrhages. See, these intraretinal hemorrhages are not very common in CNVM. Most of the times we tend to see subretinal hemorrhages. So when you see intraretinal hemorrhages, fibrovascular PED, elderly patient, think of RAP, do an ICG, then you might have to modify your treatment plan. So similarly in IPCV cases, we know IPCV can be treated both with anti-VEGF, but the best response obviously comes when you target the polyps. With anti-VEGF, you reduce the exudation, but you are not really killing the polyps. To kill the polyps, you need either some sort of laser or PDT. So you can see this is a case where there is a lot of fibrovascular hemorrhagic PED, few hard exudates, few hemorrhages here. This is a fundus fluorescein angiogram, blocked fluorescence, and there are some hyperfluorescent areas. We are still not sure whether it is a CNVM or it's something other. You can treat this patient with anti-VEGF. If you treat this patient with anti-VEGF, the patient will respond also. It is not that the patient will not respond, but the patient will come back with recurrence. And then you landed more trouble, because more the bleeding occurs, there is more scarring, and the chances of good visual recovery keeps coming down. So always we have to come at a definitive diagnosis. So the moment we do ICG, you can see there are a cluster of hot spots. So any hyperfluorescent lesion in ICG is known as a hot spot. So you can see at the top of this hemorrhagic PED, you can see small, tiny spots. So these are the hot spots. Then this seals the diagnosis. This is a case of IPCV and not just a clear-cut CNVM. So how do you treat this patient? How does it make it different, our treatment? So this case, as you can see, is just juxtafoveal. So we decided to do laser in this treatment, in this patient. So see, after the laser, this is ICG angiogram. After the laser, you can see there is resolution of the polyps. So these are the polyps, the hyperfluorescent areas. The moment you do laser, it is gone. So the basic idea of doing ICG is to differentiate similar AMD lesions like IPCV and RAP, because their treatment is just not anti-VEGF. They will need either laser or PDT. So coming to other areas where we sometimes need ICG is central serous retinopathy, required in very specific case scenarios, basically in chronic recurrent CSR. In cases of chronic CSR, ideally we don't see a single area of leaking point. Rather we see, as Dr. Shubhija has shown, a sick RP with multiple leaking areas or a diffuse area of RP leakage. So what you basically see in CSR is there are dilated, hyperpermeable choroidal vasculature. So if you are planning PDT in CSR, which we do in cases of chronic CSR, we do ICG to find out all the areas of hyperpermeability and do multi-spot PDT. So single spot PDT here will not do, because all the areas are hyperpermeable. So you have to treat the whole area. So that is the idea of doing ICG in CSR. Another interesting case is retinal artery macroaneurysm. As we all know, it is a severe bleeding disorder in elderly gentlemen or females, hypertensives. The peculiar thing about retinal macroaneurysm is it can cause bleeding in all layers. It can cause a vitreous hemorrhage, pre-retinal hemorrhage, subretinal hemorrhage, choroidal hemorrhage also. So the problem with FA here is the overlying hemorrhage. So advantage of ICG is you can actually delineate where it is leaking from. So here is the patient with a lot of pre-retinal blood. There is a subhyaloid blood here. There is little subretinal blood there also. So we do a fluorescein angiogram. We can see something happening here. Rest of the part of the retina we cannot see, the choroid retina, because everything is obscured by blood. So the moment we do ICG, you can see that it clearly delineates where the macroaneurysm is, and you can treat that macroaneurysm either by laser or whatever means you decide to. But it is very crucial in diagnosing disorders where there is a lot of pre-retinal blood and you want to know what is happening beneath it. So another interesting situation where we tend to do ICG nowadays is an inflammatory situation. Sometimes we see a patient like this, 45-year-old myopic lady comes with the OS metamorphopsia, and you do a fundus fluorescein angiogram. Again, it is not very informative. You can see some sort of hyperfluorescent dots. You don't know what the diagnosis is. The moment you do ICG, you can see clearly hyperfluorescent areas. So these are very characteristic of diseases like sphincter inner choroidopathy, which are exclusively responsive to steroids. So these are a set of conditions where probably we need ICG to delineate and to exactly know from where the lesion is coming and to treat them. So thank you very much, and I take this opportunity to thank my mentor and mentor of lot of ours, Dr. Professor Krishnendu Sarkar, who unfortunately passed away just couple of days ago. Otherwise, we would have loved to hear from him more about all these things. He actually initiated most of us in this part of the world into ophthalmology. Thank you very much.